So we've talked now about some different types of measurements and how to assess prevalence, incidence, associations, and prediction. We've thought about causality, but now we're going to turn a page to designing a study. We've decided that there is an association out there, or a prevalence or an incidence out there that we don't know enough about, and therefore we want to study it. The first thing to do is, and this might seem sort of obvious, is to state a research question. What is it that you want to study? Some of these things might seem given or trivial because you've thought about your area of study for a long time, and so you know this already. But it's still worth thinking through these because these will guide the rest of your study, the initial research question. So first, what is it that exactly is it that you want to study in terms of exposure or treatment? Is it the exposure to risky drinking? And if so, according to which criteria? Secondhand smoking, again, every day or every week? BMI overweight, or both BMI overweight and obese? Is it a treatment? So maybe it's a mobile phone app for physical activity. Is it cognitive behavior therapy for anxiety? You need to define what you actually mean by exposure or treatment. It doesn't have to be binary. It could be multiple different exposures that you want to study, or even continuous. You could look at, for instance, BMI over a continuous scale if you wanted to. We're going to think about it as binary just because it's simpler to discuss, but in reality, everything we say here can be applied even if it's not binary. A bigger question maybe is, because you probably thought about this a lot, but what are you comparing against? What is the comparator? So are you comparing against non-risky drinkers, or are you comparing against abstainers entirely? Or are you comparing to those who have never been exposed to secondhand smoking, or those who are only exposed monthly? Are you comparing to people with normal weight or underweight individuals? Are you comparing to referral to primary health care clinic? Are you comparing to a waiting list or no treatment or placebo? And same thing here, it doesn't have to be binary. This could be multiple different exposure treatments or comparators, or it could be continuous. Okay, let's move on. What about the outcomes and harms that you need to consider? What exactly is the outcome and how should it be measured? If you're going to have risky drinking as an outcome, according to which criteria and how are you going to measure it? Secondhand smoking, again, according to which criteria, how are you going to measure it? BMI overweight or BMI both categories, how are you going to measure it? Is it the number of minutes spent on moderate and vigorous activity? How are you going to measure it? Is it symptoms of anxiety, and how are you going to measure it? So you need to really think about what outcome is relevant for this study and how you're going to measure it and how you define it. And then you should also think about the harms that your treatment could induce, and you want to be able to monitor them. So maybe adverse reactions to drugs, or you could have an opposite effect of your intervention. There has been examples of, well, the evidence is weak, but there have been examples of individuals actually drinking more when they get support for drinking less. Well, the intention was for them to drink less, but it actually supported their drinking. Increased levels of anxiety and stress are not unusual to come across when it comes to, for instance, behavior change. If you've been smoking for a long time and use it as a de-stressor, the first few weeks without cigarettes can be quite stressful. So harms is something that you all should be considered alongside the outcomes that you're actually looking for, the more positive outcomes. And then you need to think about follow-up. So when to do follow-up is going to be closely tied to what you're measuring. If it's adherence to a program, if, for instance, if your study is about are people taking a pill each day, if that is your question, then obviously you need to measure this regularly to know. If it's smoking status in a smoking cessation trial, it might be enough to just measure at the end of the intervention program. Incidence of death or disease at regular intervals to catch all transitions at appropriate times. Long-term health consequences may require many years of follow-up. How are you going to deal with loss to follow-up? Patients move away, they're no longer able to respond to calls, otherwise incapable of supplying data. Is it ethically and economically justifiable to include a certain length or number of follow-ups? So, for instance, in digital intervention research, it's quite difficult to retain people in a study, depending on how they actually enter the study, but if it's a sort of a general population outreach program. So if you decide that you want 12-month follow-up, if you know beforehand that you're only going to get 30% responses, it's actually unethical in some cases to even consider a 12-month follow-up, because that 30% retention is so low that that data isn't really useful, yet you collected it from people, and if you collect data from somebody, you should use it. Do you have any plans to increase the retention? This could be incentives or otherwise. And then how do you plan measuring harms? Should individuals self-report any harms they experience? Should you be reading medical journals to follow them up if there are any adverse events? Should these be measured at the same interval as follow-up, or is there a different interval you should measure the outcome here, not as follow-up? These are follow-ups, obviously. So should these be measured at the same interval as the primary outcome here? And sometimes follow-up isn't needed. In retrospective studies, you might already have all the data you need, and in cross-sectional studies, you have all the data at one point in time. So you've gone through the first few stages, and you've decided on the exposure or treatment, the comparator, the outcomes and harms, and follow-up. Now it's time to do a sanity check. Recall that associations are contrasts. So an outcome may be associated with one exposure, treatment, and comparator contrast, but not another. It could be the case that you have a mobile phone app for physical activity, and this one, if you contrast it against referral to primary health care, then you might not see an association with number of minutes spent on moderate and vigorous activity. But if you contrasted it against a placebo, then you might. Or no treatment at all, then you might. So, does it make sense? Does this pair of exposure, contrast, or comparator, does that contrast make sense? Is that congruent with the research question that you want to ask? Also remember that an exposure, treatment, and comparator contrast might have an association with respect to something else than you measured. So you might have decided that you wanted to measure number of minutes spent on moderate and vigorous activity. That was your outcome that you're interested in. And you might find that the effects aren't that big of your app or whatever. That doesn't mean that it doesn't have an effect on something else, like sedentary behavior, but you didn't measure it. So, are you measuring the right thing? How large should an association be for it to be important? And do you think that you're going to find this kind of association? If you don't think so, then maybe it's unethical to go ahead with the study. What are you going to use these findings for? And does the exposure, treatment, and comparator make sense? So, testing a novel treatment versus no treatment control may not make sense if there actually is an alternative out there. If there is an app that has been provenly effective in increasing physical activity, then if you're designing a new app with some novel treatment component, it might not make sense comparing to nothing at all, because there's already some alternative out there which you should be better than. You're not comparing to nothing else. And this really goes hand in hand with, what do you believe that the comparator, the natural comparator, is? So waiting list designs where you say group A is going to get the treatment while group B is going to wait for treatment. They're going to get the treatment later on. That's sort of a strange design in some cases, because the natural thing an individual would do is not wait for treatment. In some cases they would have to, because lack of resources. In others, not. And so you have to ask yourself, the control or the comparator that I'm using, is that the natural comparator that somebody else would pick? Or is it very different from the real world comparator? This all ties into what you want to do with your findings and what kind of results you're expecting, or what kind of question you want to answer. And once you've thought about these, ask yourself, should you revisit any of these? Is there other outcomes that are important? Is there other comparators that are important? Is the follow-up interval not really in line with your research question? So make sure that you've decided upon these 4 and had to think about them before going further. The next step is to figure out what your population is and the setting. You need to decide what is the population, because it's going to help you get a sampling frame, and you also need it for generalization. So is the population university students, for instance, cancer patients, unemployed, etc., etc.? What do you call this population? It helps us to generalize your findings. If we do a study within university students, then that helps us to generalize your findings to other university students. Another thing to think about is this population seeking treatment at a clinic? Are they searching online for help? Have they been contacted proactively as part of screening? What is the mindset and what is the setting in which this population, or you're going to draw a sample from this population? And without a population, well, it's impossible to know for whom we should generalize the findings. And why do we want to generalize? Well, we rarely include the entire population in a study, and we rarely care about the associations within the sample only. We want to generalize to all university students, all cancer patients, and so on. So just to illustrate that, you could say, well, I have a bunch of university students here, cancer patients here, unemployed here. And this population here would be university students who visit the student healthcare website. These may be cancer patients that visit the clinic. These might be unemployed people who look at newspaper job ads, and that's how we're going to recruit them. So here we would have a study among cancer patients who visit a clinic, and here we wouldn't know what we're studying. It would just be a mix of everything, and it would be hard to generalize beyond our sample. This is sort of an extreme example, but you get the point. After you've decided on the population and the setting, you have to think about inclusion and exclusion criteria. Are you really going to let everybody who belong to the population also be part of the study? Or do you want to somehow select your participants? For instance, scoring 3 or more on audit C, for instance. That's an individual who might be in risk of having problematic drinking, so they should be included. Or you have a BMI greater than 30. You had surgery in the past 12 months. You have access to a mobile phone. You speak a certain language or live in a specific area. You're 18 years or older, and so on. So who's eligible for inclusion in the study? And the other coin is then exclusion. Who should not be included in your study? Perhaps some people presenting symptoms of severe depression are not appropriate to include in your study. If you have a history of eating disorders, then some treatments might not be well suited for you. If you're in treatment for alcohol use disorder, you've taken part in a similar study in the past 12 months, you're pregnant, etc., etc. So you need to define who is eligible by defining inclusion and exclusion criteria. Something that I think gets overlooked is that I like to think of these criteria as both implicit and explicit. So if you haven't listed a specific language as an inclusion criteria, yet it's obvious that this treatment is only available for a specific speaking, if you speak a specific language, then that is implicitly going to be an exclusion criteria if you don't speak that language. Maybe there are certain motor skills or being able to read or see or hear that you have actually listed, and those are implicitly going to exclude individuals. And always, participants that are not willing to actually take part in a study are always implicitly excluded, unless you use deception, which I'll talk about a little bit later. It is tempting to have very strong criteria sometimes. include only those with very high risk, it increases your statistical power and fewer individuals and reduces costs. Adverse events, which may lead to termination of a study. So you only enroll participants who have a high probability of the outcome, yet a low probability of side effects of the exposure treatment, because you don't want your study to be shut down. And individual beliefs. For instance, old people might not be able to use digital intervention as intended, and so you exclude old people. The problem with very strong criteria, and in fact the problem with all of these, inclusion, exclusion, any type of criteria, but specifically with strong criteria, is that the eligibility criteria manipulates the choice of population. The population you've decided on has become something different. They're very much a selected population. And the question is then, will you still be able to generalize your findings to the population you intended? So if you said, well, I want my population to be university students, well, if you decided that only Swedish-speaking university students are allowed because all the materials are in Swedish, well, then it's not all university students anymore, and so on. And so these two go hand in hand, the decision of the population and setting, along with the criteria that you set. And the stronger criteria you set, and in these cases they are quite extreme, these are 3 extreme sets of criteria, you are really manipulating your population, and so you might not be able to generalize in the way you expected. Okay, so here is an example of just some cutouts from a protocol to give you an idea of what these considerations might boil down to in a study protocol. So this is a protocol for reducing alcohol consumption among risky drinkers in the general population of Sweden using an interactive mobile health intervention. So we can see here that the population is the general population of Sweden. Risky drinkers, that gives you a signal that there's some kind of inclusion criteria here. The outcome seems to be alcohol consumption, and the idea is to reduce it. But it doesn't really say what the comparator is here. So the authors might want to revise their title. Later on in the protocol, we have the objectives listed. It says that one of the key objectives of the study is to validly estimate the effect of the novel intervention on alcohol consumption among risky drinkers in the general population of Sweden in comparison with a health information control condition. So here we get the comparator. Here it says actually in comparison with a health information control condition. Maybe the authors thought that the title was going to get a bit lengthy if they also included that. And then there are a set of other objectives not listed here. There is a definition here, what risky drinking actually is intended to mean in this particular study, which is either drinking more than 9 or 14 standard units of alcohol per week, or drinking more than 4 or 5 standard units of alcohol on a single occasion, at least once a month. And here standard units are defined as 12 grams of alcohol. So sort of a definition of what we mean by this risky drinker criteria. The outcomes are total weekly alcohol consumption and frequency of heavy episodic drinking. And there's a secondary one, which is classification as risky drinker according to Swedish guidelines. There are 3 follow-up stages, 1, 2, and 4 months after the randomization, and all follow-ups will be initiated by sending text messages to participants with hyperlinks to questionnaires. So here it's also emphasized how the outcome is going to be assessed. Then the setting is using web search engine advertisements and social media. We'll target individuals in the general population of Sweden seeking help to reduce their alcohol consumption. It didn't say in the title that these individuals were searching online for help. So that does eat up part of the general population, because not everybody in the general population are searching for help online. So the title here is a little bit misleading, but again, it might not have fit the journal guidelines of length of title if we included everything. So there's a balance. Hopefully the authors put all this in the abstract. And then all individuals giving informed consent will be asked to complete a baseline questionnaire, which will allow to assess eligibility for the trial. The inclusion criteria will include those the following: aged 18 years or older, ownership of a mobile phone, and being classified as a risky drinker according to Swedish guidelines. Okay? There are, however, some implicit exclusion criteria here. For one, it doesn't actually say here, but the intervention is all in Swedish, so you have to be able to speak and understand Swedish. If you're not an individual who searches online, then you'll be automatically excluded because you're not going to find the study if you haven't looked for it, and so on. But obviously, we can't think about everything all the time. Some stuff is going to be not mentioned and be implicit here. And that's just the way it is in science.